Hello, good evening everyone. So today is lung capacities and lung volume. So what is the actually meaning of this lung capacity and lung volume? Lung capacity and lung volume, it means the capacity of the lung to accommodate, actually accommodate air. Now what is the purpose of studying this lung capacity and lung volume? Purpose is to assess the inspiratory and expiratory muscle condition. This is one reason. Another reason is to have an idea about any abnormality, that is clinical condition, any abnormal condition affecting the lungs respiratory function. Now, this lung capacity and volumes, they are assessed or measured and also represented in two ways. Now, two types of this lung capacities and volume are the static lung capacities and volumes. The second one is the dynamic volumes and capacities of the lung. So, the static lung capacity and volume, it is only the measure of volume of air within and is only measured in ml or liter. That is only within, it is only the function of the volume. It is not dependent on time. So whenever we are measuring and designating or talking about the static lung capacity and volume, we confine only to the volume, like how much volume is within the lungs or its capacity to hold the volume of air within the lung, no matter how much time it takes. But here, the volume is related to the unit of time. So, for example, it is expressed as ml per minute, like that. Ml per minute or liter per minute. Usually, ml per minute is the most convenient one. Now, the type of the static lung volume and capacity. So, static lung volumes and capacities are. What are the static lung capacity and volume? First is the tidal volume, the most common one and very important one also, an important parameter. And one more thing, all these lung capacities and volume, especially the static one, this is measured with a spirometer. The spirometer is essential to measure this capacities and volumes. So tidal volume, it is the amount of air that is inspired, that is breathing in, and expired per breathe. Like every time a person is breathing, how much volume of air he or she is breathing in and out. So it is about 500 ml. This is the tidal volume. This is the roughly it is like 500 ml. Second is the inspiratory reserve volume. So inspiratory reserve volume, reserve, there is a term which is called as the reserve. So inspiratory reserve volume. Now this is like after tidal volume, that is normally we are breathing in and breathing out. That is using the inspiratory muscles that is used during the quiet breathing. Now if after this tidal volume, we want to fill the lungs with extra volume of air by exerting more pressure, that is forceful, not the quiet breathing, the forceful breathing. So, inspiratory reserve volume, it is the amount of air that can be forcefully inspired, that is maximally forcefully inspired. This is about 2000 to 3000 ml depending on the capacity of a person, and usually all these volumes they're slightly higher in males compared to that in female. Third we have is the expiratory reserve volume. So expiratory reserve volume. This is the extra amount of air that can be expired out forcefully, and its quantity is about 1000 to 1200 ml. This is the expiratory reserve volume. Then we have the residual volume. Now, residual volume, this is the volume of air that cannot be expired out. Means this is the amount of the air that is staying in the lungs even after forceful expiration. Like that cannot be expired out even after forceful expiration. Now this is about 1200 to 1300 ml. These are the various volumes of the air that is in the lungs. So this residual volume, it is kind of a air that is always trapped in the lungs, and no matter what we do, it cannot be expired out even by forceful breathing out, forceful expiration. Now this residual volume also prevents the lungs from collapsing. It will prevent the lungs from collapsing. These are the static volumes. Now coming to the static capacities, I am writing it together, static capacity. Inspiratory capacity. Now inspiratory capacity, how is it measured? It is the tidal volume plus the inspiratory reserve volume. So say in a person the tidal volume is 500 ml and say for example the inspiratory reserve volume is 2500 ml. Okay, both are ml. So the inspiratory capacity is 3000 ml. Okay. So this means it is the total amount of the lungs which has the capacity to have or breathe in air above the tidal volume. That is the maximum capacity in a person's lungs. Similarly, expiratory capacity. This is tidal volume plus expiratory reserve volume. 500 plus, say for example, the reserve volume in a person is about 800 ml. Just an example I am taking. Okay, or okay, for easier understanding, let us make it 1000. So it would be 1500 ml. This is the expiratory capacity. We have the vital capacity. Now, vital capacity, this is a very important parameter which is even performed in athletes or even in school sports or college sports to assess the capacity of a person's lung during performing an exercise also. So, this is very important in sports physiology. So, vital capacity, it is tidal volume plus inspiratory reserve volume plus expiratory reserve volume. So it is something which is between 4500 to 5000 ml. This is roughly up within this range. The total, this is also VC, designated as VC. So, and here inspiratory capacity IC and inspiratory capacity is total lung capacity. The total lung capacity or TLC, it is the maximum amount of air that the lungs can accommodate. Means by maximally breathing in and by maximally breathing out. Okay, this is what we get in inspiratory capacity and expiratory capacity. Now, in case of total lung capacity, it is the maximum capacity of the lung to accommodate the air and also to let it out. Like how much maximally the lung can stretch and how much total volume of air the lung can accommodate during the process of breathing. It is about 6000 ml. Maximum it is about 6000 ml. Now this total lung capacity, it is calculated as tidal volume plus inspiratory reserve volume plus expiratory reserve volume plus the residual volume. Right? So this three, it is vital capacity plus residual volume. So total lung capacity can be measured by calculating the reserve volume as well as the vital capacity, and it gives a very good understanding of the condition of the lungs during the process of respiration. If there is a condition of the lung, if the elastic fibers are okay, all this thing also reflects in all these volumes and capacities. Now, these are the starting volumes and capacities in which we did not need the minute. But here is this dynamic capacity and dynamic volumes. Now, this in dynamic lung capacities and volume, the important are the functional or rather we call it, which is easy to remember, forced vital capacity or timed, because this is the one that is most in use, vital capacity. Now, this forced vital capacity is used in the clinics to understand the condition of the lung if there is any kind of obstructive and restrictive diseases of the lung, which we will correlate eventually. Now, what is the forced vital capacity? Like here, the person's nitrogen content is measured while the person is made to expire maximally. Okay, the person is made to expire maximally after that person has been made to inspire a known concentration of nitrogen. Now, why a known concentration of nitrogen? Because nitrogen never gets exchanged at the level of the lung and it does not interfere with the process of exchange of gases. So, nitrogen that is present in the inspired air from the spirometer, that 99.9% it comes out as it is. So, it is easy to detect. But other gases like oxygen and carbon dioxide, we can't, because they participate in the process of gaseous exchange of this, in the process of respiration. And other gases we can't use because gases like sulfur dioxide, carbon monoxide, they are toxic to the respiratory system, toxic to our body. So, the safest air or the safest gas component of the air that is used to measure is the nitrogen. So, by a graph, we will understand this one. After this, we will come to the measurement of the static lung volume. So, what is done is the person here, not this one, the person here is asked to expire maximally after inspiring a known concentration of the gas. So, as we can see in the graph, I am zooming it out. Okay, I think it's clear now. So, first, the person is made to inspire like maximally. This is the tidal volume. After the tidal volume, the person is made to inspire maximally, in which there is a known concentration of nitrogen. And after that, as we can see the graph that is going down, the person is made to expire forcefully. Now, when this person is made to expire forcefully, first, after 1 second, the forced expired volume, this is what we call as the forced expired volume at first second, like after 1 second of expiration, breathing out, this content of the nitrogen is measured. Okay, and then at the second, second like V2, and the third second, which is FV3. So here what is seen is that maximum expiratory flow rate is studied during the 25 to 75% of the expiration. Meaning what? When 25%, to 75% of the air is being expired. During that time, the rate of the expiration is measured. Now here, normally it is 300 liter per minute. This is the rate of expiration. If there is any blockage, if there is any obstruction in the pathway, then this value will be less. This is the forced vital capacity measurement using the graph, using the forced expired volume. Now, this whole thing, it is used to understand two conditions of the lung. The two conditions of the lung which is used to be checked, which is used to be detected, are the obstructive lung disorder. Second is the restrictive lung disorder. So first the definition, what is the obstructive lung disorder, and then what is the restrictive lung disorder. In obstructive lung disorder, what we see is that there is a blockage in the expiratory pathway. There is a hindrance in the expiratory pathway. Example, emphysema. Like COPD, example of COPD, emphysema. Here what happened is a chronic obstructive pulmonary disorder, COPD. So here what happens, the lung is expanding. The compliance is normal, but the elasticity is hindered. The elasticity is like lost due to any reason. The most common reason is emphysema, which is the loss of elastic fiber, especially seen in older people. So, when there is loss of elasticity after inflation, the lung cannot come back to its original position. The lung is like arc-shaped. Therefore, the expiration becomes less. So, here what happens? The FEV becomes lesser, but the FVC is normal. In case of restrictive lung disorder, what happens? The inspiration is affected. Okay. Example, fibrosis. So, the compliance itself is affected. There is stiffening of the lungs. So, since there is like less compliance, the lungs did not stretch at all. The forced vital capacity is less, but the FEV is not affected because the elastic fibers are not affected. It is the compliance, the stretchability of the lung that is affected. The lung is not able to inflate, not able to accommodate the air it is supposed to, but the inflation is less, but the elastic fibers are normal, so the deflation is normal. Now, this whole thing is calculated by a ratio of the FEV by FVC, which is normally less than 0.8. It should be less than 0.8. It should be like less than or equal to 0.8. It should not be like higher than 0.8. It should not also be too much less than 0.8, or rather it should be equivalent to 80%. This value should be near about 80%, not too much above it and not too much below it. So if we see this in the graph, it will be represented like this. So this is how we differentiate the possibility of a lung to have restrictive or obstructive disorder. So in a normal person, in a normal condition, when the person is made to inhale maximally and exhale maximally, that is FVC, it is about like 5, and the FEV1 is like 4 in the first second. That is between the 25 to 75% of the expiration. So difference, the ratio between the two, that is like 4/5, it is about like 80%, which is like 0.8%. This is in a normal lungs. But in an obstructive lung, where the inflation is normal, but the deflation is not, because there is loss of elastic fiber. Here what happens? Here the FVC, the forced vital capacity, is somewhat little higher. It is not too much low. But the expiratory volume is very less because the lung cannot deflate to its original position. So more and more air is staying in the lung, causing dead space. So there is more trapping of the air in the lung. So if a ratio is done, it is like much lesser than 80%. That is much lesser than 0.8, which is indicative of an obstructive lung disorder. Now the opposite one, restrictive lung disorder, when the expansion of the lung is restricted, when the expansion of the lung is restricted. So when the expansion of the lung is restricted, automatically the forced vital capacity is also not very high. It is about 3. It can also be less than 3. But since the elastic fiber is not affected, the expiration is normal. So by the difference, if we do the ratio, it comes to about 90%, which is more. So here we see in a normal person, the ratio is 0.8. In an obstructive lung disorder, it is much lesser than 0.8, and in restrictive lung disorder, it is greater than 0.8. So these values are indicative of the obstructive and the restrictive lung disorder. This is how we measured a part of the dynamic lung capacity. Now static lung capacity and volume, static lung capacity and volume can be measured by nitrogen content in Douglas bag. Now, what is the procedure here? The person is made to breathe into the Douglas bag, and from there the nitrogen content is measured. So what is the formula to measure that nitrogen content? The formula is like functional residual capacity. Here, the static lung volume that we are going to measure here is the functional residual capacity, which we spoke about in the last class. So, last 2 classes we mentioned about the functional residual capacity. So, very quickly, just a reminder, a very quick reminder, what is the functional residual capacity? After tidal volume, it is the air in the lungs above the residual volume, right? Like after the normal breathing, the amount of the air that is staying in the lungs, not after forceful breathing, but after normal breathing, that is staying in the lungs, is a functional residual capacity. And we have also studied that it maintains the equilibrium. We have seen the graph. It is important for maintaining the minimal expiration and inspiration when we are not breathing in and out, like between two breaths, when we are not actually taking in air or taking out air, it maintains the buffering of the lungs and carries out the minimal expiration and inspiration, that is respiration, without which the lungs would collapse. Okay, now this FRC, here it is designated as like V2. In case of this Douglas bag method, it is like V2. Now, it is measured as V1 into C1 by C2. Now, what does it stands for? This V1, it is the content of the nitrogen from collected air, that is from in the Douglas bag, and similarly C1, it is the concentration, this is the content amount, and this is the concentration of nitrogen in the collected air, that is from the Douglas bag, whereas this C2, it is the concentration of nitrogen in the air. So, by measuring, calculating all this, we get the FRC, which is V2. This is like the most accepted and supposed to be the most accurate measurement of the static lung capacity and volume. Other than that, also earlier there was another method in which it was a spirometric method in which nitrogen was added at the end inspiration, but then a lot of error was found related to that, so it is like kind of not so much in use. So it's enough if you remember this one. Now, interesting and important point that we have been discussing, like last class also we spoke about the inspiration, expiration, all this thing. Today we spoke about the restrictive and obstructive lung disorder, and we have discussed the capacities and volume. Now, what is the applied part of it? The applied part lies in correlating all this information into the low volume curve, and then we have the loop also, flow volume loop, we will come after that. So now, what exactly is a flow volume curve? So here, the flow volume curve is something like this. Okay. The graph that we see here you see in the middle, we have the horizontal line. On the left side, of this line, what we have is the total lung capacity. You know what is total lung capacity? And the right extreme, we have the reserve volume, which is the air trapped in the lung even after forceful expiration. Okay. And this is our tidal volume, the normal quiet breathing, and tidal volume, and this is the equilibrium point, which is the functional residual capacity, which is maintaining the respiration. Okay. Now, there are two conditions, like one, when the lungs is breathing in and out at a low volume, like breathing in, inspiring less volume of air, expiring less volume of air. Obviously, if you inspire less volume of air, you have to expire less volume of air. Second one is when the lung is inspiring forcefully more volume of air and obviously letting out more volume of air. So here one thing to remember, this flow volume curve is a sensitive measure to detect obstruction in the airways. During respiration, what are the obstruction in the airway? This flow volume curve, it is a very sensitive way to measure that one. Why so? So here you see at the lower lung volume, means when the lung is accommodating less volume of air. So lung is accommodating less volume of air, means from this tidal volume all the way till the reserve, this residual volume. So if we go through if we follow this continuous, this strong, this solid lines, this is at the lower volume. So at the lower volume, the effort below, just below the vertical line, this loop that we are seeing, this is indicative of the inspiratory curve. This is the curve when we are, the flow is like within, like inside the lungs. When there is flow of air inside the lung, which is inspiration, that's when the flow of curve is there. That is below the horizontal, the straight line. And the inspiration, it is represented just above the line, horizontal line. Now, effort is more when there is expiration. So, as we can see from the solid continuous line which I have highlighted, when the lung volume is less, like when the lung has inspired less amount of air, then the effort to expire, to let it go, is minimal. Okay, it is minimal. Now, when the lung volume increases, like the bigger loop, this is the inspiration, the lung has expanded. The lung has expanded. This is at higher lung volume. Then the effort to expire also reaches maximum. Like larger amount of air enters the lung and lot of effort, lot of squeezing, lot of contraction of the expiratory muscle is also needed for the lung to let out that much amount of air. And then you have this intermediate volumes also, where intermediate effort is required. Now, what is the significance? What should we learn from it? Now, the topmost part, from where? Like after maximally inspiring, this is our maximal inspiration, max inspiration. Now, this is the point from where, like, the lung is now exerting the pressure, the force with the help of the expiratory muscle to expire. So this is the peak expiratory volume, peak expiratory rate, PER. Now, this PER, when the beginning of expiration starts after the lung has inspired lot of air, then the beginning of expiration always needs a lot of pressure, lot of effort, lot of contraction of the forcefully used muscle. We have studied there are muscle which is used during quiet breathing and also during forced breathing, right? So those muscle, their maximum contraction is needed, maximum effort is needed by the lungs to let out the air. So PER is always force dependent. One. Now, by the time the process of this expiration starts and the volume has reduced, right? The expiration has reduced. Eventually, it merges. Later on, it merges to this effort independent area. Later on, it is the effort independent area. Now, midpoint point after the peak expiration has started. It is the maximum mid expiratory flow rate. Now, this mid expiratory rate is effort independent. Now you might be thinking, okay, so what? One is effort dependent, another one is effort independent. How does it matter? How does it matter is that in effort dependent stages, the intrapleural pressure can be forcefully altered, to expire more air. Okay, because it is effort dependent. It is effort dependent. Okay, but in effort independent, because the volume is so less, effort independent stage, the alveoli, that is the lower alveoli, that is the lower alveoli, they start to close down. They start to close down, as a result of which, so decrease in pleural or alveolar pressure cannot increase. It cannot increase expiratory rate. Okay, it cannot increase the expiratory rate. So this is the importance of the low pressure volume. Okay, this is the important of it. So what is the take of it? Like when the lung volume is less, that is less amount of air has entered the lung, the expiration does not need any effort, and not only that, since it does not need any effort, the rate of respiration cannot be increased also, because at that volume the lower alveoli will start to close down. But when it is at higher volume, when it is at higher volume and it reaches the peak expiratory rate is always dependent on effort, and later on it merges with the effort independent region. So the effort dependent region, what it can do, it can increase the expiratory force, expiratory flow, if needed, by altering the interpleural and intraalveolar pressure. Okay, this is the importance of it. Now, how does a pressure volume loop looks like? The flow volume. Okay, the flow volume. The flow is the one that is giving the pressure. Flow volume loop looks like. This is a very, very conceptual thing and are very much used to assess various conditions of the lungs. So, here we see. Okay, so as I told you, here we see this is a very sensitive way to measure the condition if there is any kind of blockage, any kind of hindrance in the passage of airway while passing the air, mainly during the expiratory region. So this is the peak expiratory flow. This is the loop, like just saying like before, this horizontal line on the left hand, it designates the total lung capacity, and on the right extreme side, it is the residual volume. So the entire area, this is the designation, this is a depiction of the forced vital capacity, like when a person is breathing in maximally with effort and then is maximally expiring out. Okay. Harish Kumaria, good morning, good evening to you also. So after maximum inspiration, when the lung capacity reaches to total lung capacity, which is about 6 liters, that is 6000 ml. Now from there, when maximal expiration happens, the first is the effort dependent point, that is the peak expiratory force. Now after that, it is the 25, like the forced expiratory flow from 25 till the 50. This is the mid expiratory flow, or MEF. Now here actually this is most sensitive part to detect any airway obstruction. And last is the last part of the expiration, which is 75, which is not so much sensitive, but yes, it can be used also. This is how a normal loop looks like. A normal loop looks like. Now, this flow volume loop will get totally changed, will get totally affected and deformed in case of obstructive and restrictive lung disorder. So we will see pictures of that, and then we will go to the other types of the dynamic lung volumes. So what we see is so this is an example of the restrictive lung disorder. So as you can see in the restrictive lung disorder, the black one, the solid one, the one black one, this is the normal. This is the normal peak expiratory rate or peak expiratory flow. Now, in case of this restrictive lung disorder, again, what is the problem? As seen in case of fibrosis, the expansion of the lung is less. The expansion of the lung is less. So here you see the inspiratory curve itself is less than what it should be. Okay, and since the volume of the air, the FVC is less, automatically the peak point is also lower. So the PER is also less compared to the normal one. That is the one that is in the solid one. So here you see the parallel slope. This is also this parallel slope. This is also below. This is also like deviated. This is like suppressed. This is like towards the inside compared to the normal one. And the maximum mid expiratory flow, which is the sensitive measurement to detect any kind of obstruction, this is also low. Low means it is like pushed towards the back. So here you see the total, and the peak is also not as sharp like this one. See, here the peak is very sharp. Here it is kind of like blunt. It is not as sharp because the inspired air itself is less because of the less compliance. As a result of which the air that is within the lung is less and the volume of the air that is also coming out is less. So this is how a flow volume loop looks like in a person who is suffering from restrictive lung disorder. Next picture. Next picture we will see of a person who is having the obstructive lung disorder. Okay. I think I don't have the picture, but that's okay. I will draw the picture for you. A person with obstructive lung disorder. So the flow volume loop will be something like this. So this is the normal curve in which we have the normal peak like this. Okay, this is a normal one. So this is the PER. In case of an obstructive lung disorder, what is the defect? The inspiration is normal. The inspiration is normal. So here, but the expiration is abnormal. Now here what will happen? The loop will be little bit like deformed. It will go downward, though the inspiration is normal and the expiration is not normal. So the expiration will be kind of scaffold and it will give a dog leg appearance. So here you see there is like kind of a scaffolding and there is like a dog leg, like a loop that has gone down because the inspiration is more and so the lung is inflated, but there is also accumulation of the gas, accumulation of the air inside the lung because expiration is not proper. So here the peak expiratory rate, the maximum mid expiratory rate flow, all are less. All these things are less and there is accumulation of gas within the lungs. So this is how the flow volume loop in an obstructive lung disorder person will look like. Now these are not the only condition in which the flow volume loop is affected. Now there are conditions also where there is like presence of hindrance. So there is like hindrance in the airway due to some extrathoracic or intrathoracic reason. Like, for example, there are this flow volume loop which is deformed whenever there is intrathoracic obstruction. What is intrathoracic obstruction? It means presence of a tumor or deformation of the trachea. It will lead through intrathoracic obstruction. Sometimes apnea also causes the variable intrathoracic obstruction. Here, the expiration, the expiratory loop or the phase is affected maximum. So here you see, because of the presence of the tumor, because of some deformation of the trachea, or because of the sleep apnea, like when there is temporary stoppage of breathing, that time what happens? The inspiration happened or is happening, but there is accumulation of the gas, and you see the inspiratory curve kind of goes very much down because of the increase in the volume due to trapping of air within the lungs. Now, there is problem in the trachea. There is problem in the passage of the air. So, there is a flattening of the expiratory flow. There is no sharp PER, there is no MMER, also no peak expiratory flow, no mid expiratory flow. So, expiration kind of comes to a standstill, becomes very difficult, becomes very slow, and the flow volume loop is like deformed into something like this. This is how the normal flow volume loop will look like. Now this variable obstruction can also be due to the extrathoracic region or in the extrathoracic region also. Now extrathoracic region, it means if there is presence of tracheal tumor or tracheomalacia, then this extrathoracic obstruction happens. It affects the inspiration, as you can see in the flow volume chart. So here what happens, due to the abnormality in a person in development of the trachea, maybe the shape and the size is gone wrong, or maybe post surgery there is abnormality in the trachea due to some reason. So in this condition the inspiration becomes very less. The inspiration is not, the loop is not like normal. The inspiration comes to standstill. The total lung capacity has decreased, and there is like increase in the residual volume, right? But this increase in the residual volume is in proportion to the total lung capacity. So the residual volume is not like too much high, but the total lung capacity, it is like less. So when this is happening, the expiration is affected a lot. The expiration has to be like forceful. It is affected the most, and the PER, that rate, becomes very blunt, and the force and the rate of expiration is very high. Okay, and it is the difficulty in breathing. It is the difficulty in breathing. So this is how the deformed flow volume loop will look in case of the variable extrathoracic obstruction. Now another condition is that in case of the third case is whenever there is any obstruction in the both inspiration and expiration, as we can see in this diagram. Suppose there has been an entry of a dust particle. If there has been an entry of a dust particle in the respiratory region, in the respiratory tract, then what will happen? So this is due to presence of a dust particle in the airway. Okay, it is a presence of a dust particle in the airway. So when there is presence of dust particle in the airway, there will be both difficulty in breathing out and breathing in. So here you see the inspiratory phase as well as the expiratory phase, both are affected. The total lung capacity is also low, and the residual volume is also proportionately not so high. So here you get this kind of a curve flow loop, which is like flattened both at the expiration and also in the inspiration. Okay, so these are the various conditions in which the flow volume loop is affected, and this is a very sensitive and good way to measure or to find if there is any obstruction in the respiratory pathway. Okay. Now, last that I'm going to show is like, that is something that I should have shown you earlier, but since I wrote it, I didn't show it then. I'll show it to you now. So it is just for a remembrance, which we are all quite aware of. This is the representation, or how the curves or the waves forms of this static lung capacity and volume look on a spirograph. So this small regular inspiration and expiration that you were seeing, inspiration and expiration, This is what is the tidal volume. Now, from the point of this tidal volume, from the point of inspiration, when maximum, like after tidal volume, after the inspiration of the tidal volume, when maximally forcefully it is inspired in, it is called as the inspiratory reserve volume. Same from the point of expiration after the tidal volume, when it is forcefully expired out, it is called the expiratory reserve volume. Now this tidal volume and the inspiratory reserve volume is the inspiratory capacity, and tidal volume and this tidal volume and the expiratory reserve volume is called as the expiratory capacity, which is not written here, but remember it is the expiratory capacity. And residual volume, it is the volume of the air, as you can see, after the expiratory reserve volume, after expiring maximally with forcefully, the amount of the air that is trapped in the lungs is the residual volume. The functional capacity or the functional residual capacity, this is like including the expiratory reserve volume and the residual volume, meaning what? After the normal breathing in and breathing out, the amount of the air that is staying in the lung, it is called as the functional residual capacity, which is of immense use in having an idea regarding the various clinical condition, and we have studied about it. Now, the total amount of the air that the lung can accommodate, which includes the vital capacity plus the residual volume, is the total lung capacity. And vital capacity, again, which is very, very important. What is the vital capacity? Vital capacity, it includes inspiratory reserve volume, tidal volume plus the expiratory reserve volume. So this is the graph to remember, which we get from the spirometer, known as the spirometer. So this is our total lung volume and capacity, with special emphasis on the flow volume loop to correlate it with the obstructive and restrictive lung disorder diseases, which is the exposure to our clinical link. Okay. Thank you and good night. Our next class, the regular class, will be on Tuesday. Okay. Till then, bye.